Hi there. In this presentation, I'm going to talk about glucagon-like peptide receptor agonists, which are GLP-1 RAs, and GLP-1 RAs and gastric inhibitory polypeptide dual agents, or GIPs. So it's got both of those active ingredients in it. But I'd like to start with acknowledging with gratitude that this presentation was created on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations, and to thank them for their stewardship of these beautiful lands. We're going to talk about GLP-1s and GLP-1 GIP dual agents. So GLP-1s and the dual agents, Ozempic would be an example of a GLP-1, and Mounjaro is an example of the dual agent. And we're going to outline the evidence and the appropriate clinical scenarios for use with this. And I'm going to talk about the precautions and dietary interventions as that is associated with this medication. So this is a chart that has many of the anti-hyperglycemic agents on it, but I'm going to just focus on the GLP-1 and the dual agents here. And it does have an overview of dosing, frequency. We've gotten away from the once daily. You may have heard of Victoza in the past. We now have semaglutide, which is once weekly, and that's Ozempic. There is a semaglutide in an oral form, and we're really seeing the dual agent Mounjaro. In terms of coverage, we're just seeing Ozempic covered, and some private plans will cover Ozempic and Mounjaro, but usually the public plans are not covering Mounjaro, to my knowledge yet, but that could change. So when we look at the Ozempic, the other GLP-1s, so you may have heard of liraglutide or Victoza, dulaglutide or Trulicity. The other two have not really surpassed Ozempic and semaglutide in its use. And GLP-1, the analog, it replaces GLP-1 that naturally occurs in the body. So when we eat, we have to tell our pancreas that it needs time for it to release insulin. And we also need to tell our brain that we feel full. If a person does not have enough GLP-1, then that message never gets to where it needs to go in the pancreas as well as in the brain. So what the drug does is it inhibits glucagon secretion, which is extra sugar, into the bloodstream. It decreases glucose levels, and it increases the satiety level, meaning they feel full faster, so that'll decrease their appetite. Some of the side effects, though, are there's definitely a reduced risk of hypoglycemia. We're giving this in people who don't even have diabetes. Really not a huge issue to deal with, but if they are on insulin plus a GLP-1, as the GLP-1 dose increases, they'll need to decrease the insulin levels, doses, so that they don't have hypoglycemia. But nausea and dizziness really make up the majority of the issues here. It usually is in the initial stages of titration, where they might feel a feeling of fullness. Some people, it's more rare than anything that they actually vomit. But some people have a feeling of nausea. But it does have excellent weight loss properties, as well as reducing blood sugars. It also has some cardiovascular and kidney protection, which has been shown in repeated trials of various types of GLP-1s and dual agents. So if it's used for weight loss only, it does need to take that, you need to continue to take that drug for the rest of your life. And that's the issue, right, is cost and access, and whether someone wants to take a drug for their remaining days, because when they do stop the drug, the weight will start to return. It's not for use currently in patients with renal disease or history or family history of medullary thyroid cancer or pancreatitis. If they have MENS 2, which is multiple endocrine neoplasia syndrome. If they have type 1 diabetes, there are small trials using it with them, but currently it's not recommended. If they have DKA, if they're pregnant or in children, it is contraindicated for that. And it can increase the heart rate by about 7 or 8 beats per minute, and a prolonged PR interval by about 10 milliseconds. So we have to do an ECG and make sure that's okay. And the dual incretin, which is Mounjaro, tirzepatide, it's also labeled as Zepbound, same drug, tirzepatide, but marketed towards weight loss only. And it replaces GLP-1, inhibits glucagon. It's the same action here, but it also has GIP in there, which has some additional benefits for it. Same side effects, and it has actually improved weight loss from the original GLP-1s, and it has the same contraindications because of the GLP-1 component. But I want to emphasize that GLP-1 and dual agents, they're not insulin. Even though they look like it, they smell like it, they are put in the same injection sites as insulin, they are not insulin and should not be treated the same way. They promote insulin secretion. So the person has to have endogenous insulin or their own beta cells that are working in order to produce the insulin enough to bring their glucose levels down. If they have type 1 diabetes and have no beta cells left, it will not be effective in glucose control. Will it be effective in weight loss? Yes, probably. Will it still have the cardio and renal protection to it? Yes, it will. So there might be a debate to use that in type 1 diabetes, but not for glucose control. So what are the physiologic effects of GLP-1? There is neuroprotection, and it decreases your appetite. So it kind of tricks your brain into making you feel full faster. Now, what you have to watch here, though, is it decreases gastric emptying. So if someone has chronic constipation, any issue where gastroparesis, where they already have kind of slowed emptying of the gut, they can either use other agents like Metamucil or some stool softeners and lots of fluid to try to combat the slowing down of the gut, or they don't use it if it's severe. It does increase natriuresis in the kidneys, and it does allow them to use their insulin better. It increases insulin secretion and decreases glucagon secretion, which is good because that's extra sugar, but it does have cardiovascular, renal safety. It will increase cardiac output, and it increases insulin sensitivity, so it allows them to use their own insulin a lot better. And the GLP-1s have improved fasting and postprandial glucose effects, particularly around the meals, right? So the clinical use of these agents, the advantages are that it's really showing excellent glycemic efficacy. So it is lowering those glucose levels, and with the lower rate of hypoglycemia, unless they're on insulin plus these agents, it means that it's quite a safe agent to use. The weight loss and reduced appetite are a benefit to many people. However, if they don't have weight to lose, this might be something you reconsider if you're going to use it for CV safety or renal safety. They might do low dose for that as opposed to the higher doses because they can't afford to lose the weight. And it does have the cardiovascular and renal benefit as well as simple titration. What are the considerations? So the GI adverse effects, of course, are always front and foremost. In the cases where a person has recurring pancreatitis and a history of acute pancreatitis, it would not be the best drug to use for them. If they have risk of ileus, then not a good, it's slowing down that gut. And if they already have retinopathy, it will not cause retinopathy in people who don't have retinopathy. If they have existing retinopathy, it could increase the progression of that retinopathy, so it would be contraindicated in that. And the cost is always a consideration, and the loss of lean muscle mass. Now, this happens regardless of how you lose your weight, whether it's intensive activity, dietary approaches, a combination of both, or using a GLP-1. Any loss of muscle mass, about 40% of it is going to be lean muscle mass. So it really needs to be encouraged that they do some strength training, resistance training, and pay attention to those muscles as they are losing the weight, if that's their primary focus for using a GLP-1. So here's a study, semaglutide versus tirzepatide. So we've got Ozempic in the semaglutide in the gray bar to the right here. and the various doses of some tirzepatide, the 5 milligram, 10 milligram, and 15 milligram in the dark blue. I want to point out, though, semaglutide, this trial was done with 1 milligram of semaglutide, which has now been increased to a potential use of up to 2 milligrams. And so we don't have a study showing head-to-head with the maximum dose of semaglutide. The study was from 2001, and the approved dose of semaglutide or Ozempic was 1 milligram. But you can see here that definitely the hemoglobin A1Cs were improved in the tirzepatide group, which is the Mounjaro group. And then if we go to the next slide, again, same trial, and they looked at body weight. There was a significant decrease in up to 40% actually difference in the amount of weight lost with the tirzepatide compared to semaglutide 1 milligram. Okay. So what do we tell the patient? Both semaglutide, Ozempic, and tirzepatide, Mounjaro, have excellent A1C lowering, weight loss properties, and a reduction in cardiovascular risk and renal risk. When you're choosing an agent, consider BC Pharmacare, private coverage, cost, and existing comorbidities. I do know that some of the companies are coming out with patient assistance programs where they pay less for it, and of course we pay less for this in Canada than they do in the States as well. And we need to provide education on how to safely titrate that, which would be start low and go slow. If they're having side effects, you're not going to want to keep increasing that dose every month as they initially recommend. You don't want to encourage the side effects to get worse. So if they need to stay 2 months on the low dose before they bump up to the next level, fine, not a problem. If they settle out very well at a moderate dose of it, halfway up, then that's their sweet spot. So we don't want to push this and impact their quality of life. And definitely we want to encourage activity with this as well as someone is losing weight. So what are the nursing considerations? If they can't eat normally, then of course we're going to do what we always do, right? So most patients would have to bring this drug in from home. They're not on hospital formularies typically. And since the hormones work in the gut and cause nausea and stomach upset, we want to make sure that we are, advising them on these next steps here. If they have excessive nausea, we want to encourage small, frequent meals, avoiding carbonated drinks, spicy foods, and that's because of the slower gastric emptying. So some foods can irritate it more and stick around more. They might have more GERD or reflux, right? And if they're showing signs of severe constipation or gastroparesis, we need to hold the drug because they need to be able to have their alimentary canal and system move properly. So it can worsen, and especially in hospital when they're under stress, taking other medications, eating very differently than home, less active than at home, that constipation and gastroparesis can get worse. If they're showing signs of pancreatitis, hold it. Those symptoms are nausea and vomiting, rapid heart rate, fever, swelling and tenderness in the upper quadrant of the abdomen, ascites, and low blood pressure. It's contraindicated for use in pancreatitis. And then I mentioned before, if they have a history of retinopathy and they're complaining of visual disturbances, then we need to notify the provider because it can worsen retinopathy in patients with existing retinopathy. So the key messages are that GLP-1s and GLP-1 GIP dual agents have proven in repeated studies to reduce the A1C more significantly than any other oral anti-hyperglycemic agent. It improves cardiovascular outcomes and most recently some renal outcomes, reduces weight significantly in most patients. It has a very low risk of hypoglycemia, but we do need to monitor and provide education on the GI side effects. Thank you.